Chair of the Board of Directors for the Olive Branch of Hope. So I'd like to take this moment to say welcome to our historical journey of Black women and healthcare. We want to welcome our viewers online as well, and those of us who are here in the audience. We're hoping that you will be able to walk away with more information today at the end of the event, with more information than what you came in with today. Now, just before we begin, I'd like for us to do the land acknowledgement. Okay, so I'll begin. So the land I am standing on today is the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississauga of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa brands. Okay, and here I'll get into my official welcome now. So at the Olive Branch of Hope, I don't know how much you are familiar with the Olive Branch of Hope. We are available. Our website's address is www.theolivebranch.ca. So the Olive Branch of Hope is a community organization which focuses on women of African ancestry, women of color, who are diagnosed with and surviving breast cancer. We are now at a pivotal time in history where we have a seat at the table and where our voices can be heard when we want to discuss the disparities experienced by Black women within the healthcare system. Since the beginning of history, it's been a real journey not only for our voices to be heard, but also to be able to demonstrate that we can make positive contributions within the healthcare system, specifically supporting our own community. Other communities are doing it, so why not us? Why aren't we included in the decision-making process that impacts our lives? Just like nurse and activist Marie Scott, who had to fight to demonstrate that she was capable of attending nursing school, and Bernice Redmond, who was the first Black nurse to practice at a hospital in Canada. Today, we are seeing the rise of more Black women within the healthcare system who are also becoming trailblazers and are changing the status quo when it comes to Black health. By observing the screen, you are right now looking at the faces of some of these women. Names that we should become familiar with within our community, some of them are Dr. Juliet Daniel, who is a professor in the Department of Biology at McMaster University, who is leading the research on triple-negative breast cancer in Black women. Yes, that's appropriate. Thank you. Thank you. Another name to remember is Dr. Aisha Lofters, who is the chair in the Implementation Science Peter Gilgan Center for Women's Cancers, Women's College Hospital, and associate professor at the University of Toronto Department of Family and Community Medicine. Another one, thank you. Another one is our very own Dr. Danielle Cuthbert, who is in our audience today, and she will be one of our presenters, and later on she will be introduced. However, you can still go ahead and give her a round of applause right now. Thank you. So we are excited that our team of presenters are here today, and they will be having engaging conversations as they share their knowledge, their wisdom, and insights on the state of healthcare within the Black community, and share tips on how we, as a community, can advocate for ourselves and learn from each other. As the saying goes, each one helps one. How will they or how will we learn unless we are taught? They will share information on our historical journey by examining related biases in the past and taking us on that journey and letting us know where we are today and how far we've come. Once again, we are glad that you are able to join us and hope that you will walk away with more information today, more information than we knew before coming here today. Information that we can share with our families, our friends, and our wider community at large. Information that we can use to help each other, help to lift each other's spirits, help to share information about cancer and the impacts of cancer, not only on the person who is diagnosed with cancer, but on their family, on their friends, and on the community at large. At this time, I would like to introduce Stacey Berry. I'll just quickly get to her bio here. So Stacey Berry will be our, should I say, MC/host for today's event. So Stacey Ann Berry, she's the founder and president of B. Stellar Group, Inc., which provides professional development workshops as well as consulting services in government relations, business development, community engagement, and strategic planning. As a former director for the Toronto Board of Health, she chaired the Public Health Champion Awards Selection Committee, served on the performance appraisal of the Medical Officer of Health Committee, and the Association of Local Public Health Agencies Board of Directors. She has a master's degree in public policy administration and law, as well as an honors degree or honors BA in history and law and society from York University. Ladies and gentlemen, please put your hands together as we welcome our very own Stacey Ann Berry.
Can everyone hear me? I do have a lapel. Happy Black Excellence Month. It's good to see so many familiar faces. Thank you for joining us. And a round of applause to Donna Reeve for the warm welcome remarks and giving that nice highlight of the Olive Branch of Hope, highlighting our nurses who have put in so much work. My late mother was a nurse and I lost her to cancer, which is why I got involved as a volunteer, and I help out with the Olive Branch of Hope's Gala. Whenever Miss Leela calls, whatever she needs, I will help, because it's a charity that's near and dear to me. So it is an honor to be here with you and to help facilitate our very important discussion with our amazing guest speakers. So I do want to start off by first introducing our first guest speaker, Lydia Joy Marshall. Miss Lydia Joy Marshall is a proud Caribbean-Canadian woman who champions issues in health equity. Lydia Joy currently serves as the president, board of directors of the Black Health Alliance, a not-for-profit organization which works tirelessly to advocate for those who have been marginalized by anti-Black racism. Academically, she lends her expertise from her Bachelor of Science in Biology from Western University and her Master's of Science in Human Genetics from Howard University. Lydia Joy consistently strives to challenge diverse groups to examine systemic disparities and has done so through many platforms, including multiple disciplinary published research, leading dynamic international workshops, and most recently, a TEDx Toronto speaker. So let's give a warm welcome to our first guest speaker, Lydia Joy.
That sounds like a lot of pressure. So it's just good morning. I think most importantly is that I'm part of community, I'm part of this journey, and I'm grateful to be here this morning. So this is not a lecture. For all of that introduction, this is a conversation. So I hope that you're ready to engage and to speak with me, not have me here by myself on a Saturday morning. So are we in agreement for this? Yes, okay. So I was asked to speak about a few key questions. And I'm going to speak about them from my lens. So the first question was really, what's the origins of our mistrust? And I could have been here for the whole day to just answer this part. I think what I want to clarify is that I don't think it's that we mistrust science or health on a whole. It's specifically in the context of where we are and whether we trust those who we are putting our care into. So, for myself, I find it's in a Canadian context, if I've been a place that myself has either not felt respected or we have a communal sense of distrust. So I think it's important to distinguish that, because we act as though, you know, Black people just don't like science, and this is not it at all. We've heard of so many great researchers, physicians, those in our community, or health practitioners and healers. And so the conversation is not, do we mistrust science? It's, do we mistrust those who are caring for us, who, you know, do they hold our bodies to the same care that we do? So I have 2 examples. I don't know if I vogue for the next slide, yes. This one comes up a little bit fuzzy, but is anyone familiar with what this image is here? Yeah. So this is one, I'm going to give a one historic example and one that's more based in the present. So this, if you can see here, is actually Dr. Marion Sims, who used to literally have Black women on display in his medical theater to learn about, whether it's gynecological problems, anything that they were trying to learn. We were just part of, you know, the furniture. It was like literally you would be brought up, clothed, unclothed, poked, potted, whether it wasn't actually for our care. It was like we were here to learn about and to help learn for the care of others. And so I think those of us who are in this Western context, we've seen times where we are brought into medical spaces and it's not for our own betterment. And I think that like collective awareness and memory of images like this, where it's okay to touch, it's okay to prod, it's okay to do this, not for our own help, is one of the things that really adds to this idea of, well, why wouldn't we trust? Well, I don't trust that you're doing it for me. This is for somebody else. And this was a quite stark example. This was, you know, a long time ago. This was in 1845, but it's something that is still, as I said, in our collective memory. So I wanted to bring a more recent example. Next slide. So this, I don't know how many of us are familiar with, but this is an injectable contraceptive that came out, I'd say, in the 80s, or was approved in the 80s. Why I bring this as an example is because we always refer to experiments like Tuskegee and things that were before, and we say this repeatedly. But in our newer history, up until the 2000s, this was a drug that was targeted and marketed to Black women. It was tested in what they said urban youth, so females between 13 and 18 in Chicago, in other areas. The initial set of trials were actually done in Zimbabwe, and later the government actually recalled and said this was not actually safe for their women. So in the early 70s, it was tested on them, and later found, you know, this is actually not safe. But again, our bodies were, well, let's see how this works, right? And the bonus for them, especially in areas in the States, was that, well, you know, these Black women are having too many babies anyways. They can't afford it. They can't care for it. And so it was like a bonus if it caused sterilization. It was a bonus if these other things happened that was not reported to us until after. So, you know, again, I look at this, and this is in the 2000s. This is not speaking at turn of century. This is not, the images from these are not, you know, black and white pictures. And so why do we mistrust? Because in our own generation, in our own bodies, in our own experiences, we have seen things where, again, was this for our betterment, or was this to see how this could better somebody else? So next question. So I just wanted to put this image up, and kind of, this is where we're gonna start the conversation. How do these type of ways of thinking impact what do we think of the Black female body? So I'm just curious from everyone, what things have you heard? How are we described? In media, this is when you get to say things that we wouldn't normally say, but what are the stereotypes? What are the things you think of when you're any of these images or you see us in the news? Just yell out, we're not ordered. Our pain threshold, yeah. Yep, strong Black women, Black girl magic, yes. Anything else that's like the stereotypes of our bodies? Sexualized. Mm-hmm. BBL. I'm like, this is something that we're always sexual no matter how we present. When I was preparing this, the first thing that kept ringing through my head was Beyonce. We bear the children and get back to business. And I think sometimes we have these things to be encouraging. I'm not just saying, some stereotypes, some things that we speak about, they're not always degrading. But what does it mean when now we have to go and get treatment, when we're seen as so strong, when we're seen as these Black girl magic, when we're seen as super sexualized? How does that impact our care? How does that impact how we're seen and how we move through the medical system? So next. So what I wanted to bring forward, so as you heard, a little bit of my background is in human genetics, so I always kind of center it here. And so diversity in itself is not bad, right? We are beautiful shades from across the world, different features that we have. And I remember when I first started studying, one thing that was so interesting to me was, we can actually correlate some of these features that are even stereotypical to there are advantages depending on where you are in the world. I remember we used to have such interesting conversation around, what is this obsession with like Black women's booties and these things? But we started to look into it and be like, there's actually a selective advantage, which was very interesting to me. So we were saying people who are in more northern areas, if you're in a really cold place, you need insulation your whole body. So you're more likely those who are able to disperse their body fat throughout their whole body are going to survive. So if I was in Iceland, it would be really good if my body was like the fat was dispersed. Whereas if I was in Zimbabwe or somewhere else where I'm in a hotter place, I don't want that type of heat around my major organs. You would overheat. And so where do we store our fat instead? In a place where there's no major organs. So, there's things about it that I think there's ways we can look at it in a healthy way and say, well, there's a reason why we see differences in different regions. It's not always something that's negative, and it's things we can learn about, and they've been developed, and we can see places across the world and the globe where we see things changing. The problem is when we stick to these stereotypes, when we limit ourselves to them. So even saying that, there's something we always say that race is not real scientifically, although these variations are, and we see things that happen more in different areas, race is still a social construct. However, in the next slide, it definitely has real consequences. So we might always say, yes, race is a social construct and this is true, but what are the social consequences to our health, to our care, to our engagement? And I think, this is what's important here. So while as a researcher, I can say, I don't have one gene to say, what's the size of your parts? What's all of these things that make you Black? I can't tell that if I was looking in a lab, but I can tell how you're treated when you go into a medical institution. And I think so it's important to us to acknowledge those differences and that impact. So next question that I was given. How have these impacted us? So again, we could have a second day on this completely of, what are these stereotypes and how do they impact us currently? I see them in so many different ways, in the care that we receive, in the research that is done, in the assumptions that are made. But I'm just gonna speak about a few, and I know we have a lot of other friends that will speak about this from other angles, but the things that I see from my part, I like this, I'm just gonna keep. So some of them we mentioned in the stereotypes we said often. This pain tolerance one is massive. It means that sometimes we are perceived as seeking, like drug seeking when we go in, because it's like, you must not really be in this much pain. You must not really be needing what you're seeking for. We're not believed, and sometimes we don't get care until too late because we present so well. Right? And there's this assumption, oh, you look healthy, you look okay, and we're not screened and diagnosed early enough because of this tolerance. I think that also relates to the idea of our mental stability. This strong Black women stereotype is like, are we offered the same type of mental health care? Is it seen when we are hurting, when we are in pain, when we need these type of engagements? I don't think it is. I think because we might not be screaming like our counterparts. Like I think about when I gave birth and I was completely silent, and the lady in the room next to me, we could hear her in the field down the road. And every doctor went into her room, but literally the reason I was silent, I was like, I've just given up, I'm about to die, that's it. And I was sitting like in my silence. And so often we present differently, right? And so what does that mean? How does that impact our care? I was not offered any of the help that she was offered. And I think it makes a difference in what our abilities are and how we're perceived or what we can do. I heard someone say about the hypersexualization. I think, it's both a safety thing, but it's also, again, in our care. I was exchanging some stories with some of my friends of when they go in for gynecological care even, and how they're perceived of what's okay to do and what's not okay to do. In the work that I'm in, we're always speaking about creating cultural safety and appropriateness. And I realized we speak about other cultures and other people of, oh, let's make sure they have privacy, they have this, they have that. And the same consideration is not given for young Black women. It's like, oh, they're okay with that. Like, they're okay. You know, oh, they came in, I've literally heard people say, they came in dressed like this, she was wearing this. Well, she must be okay with whoever being in the room or whoever touching her, however. And I think there's not a same value put on, you know, our privacy and our autonomy and how we see ourselves because of how we're portrayed. And it definitely impacts the care that we're able to receive. And I think sometimes, you know, we forget that we're dealing with both. So we both deal with this anti-Black racism and misogyny from inside and outside of our culture. So this also impacts our care. We're just seen as either we can do it ourselves or, you know, there's a different lens in which we're recorded. You know, I worked in health records for a very long time, and the descriptions I would see, I would always know if it was a Black woman especially. You know, it would be a little bit of this unfortunate aggressive woman. So we didn't see Black, but I saw the synonyms for it. And so how does that then impact when, you know, this patient is taken now to someone else and they've already been given these ideas of who we are and how we present? And I think that impacts profoundly the type of care we get. The last thing, and there's so many other ways that this impacts us, but for me and what I see is there are actual measurements that are different for us. We have race-based corrections. And I want to remind us of what I said of, you know, race is a social construct. So why are we using these social constructed markers for clinical markers also? So we know that there are things that are more prevalent in different areas because of, as I showed in the map, and because we showed of our genetic migration, we know there's areas where you might have more prevalence, but that is not the same as being able to diagnose need based on this category. In the work that I've done, we've seen people that they've done race corrections in organ donation, and it means they won't end up on the organ list because they are perceived to be healthier, because we have corrected that as a Black person, they don't need to be on that level. There's similar calculations in prenatal screening. There's similar calculations for when you're getting your anesthesiology. It impacts so many different things. And so these perceptions are not just a matter of you don't feel good or you don't feel safe. They have real clinical manifestations and results. And so we need to question these things. So the last thing I just wanted to bring up is like, what can we do? I don't want to be the first speaker in the negative, you know, leave it on that. But, you know, I know we'll talk about this throughout the day, but I think there's some really key things that we have to do, and it starts with challenging things that we assume are normal, challenging things that have been put into the system that we just think, hey, that's clinical, that's how it has to be. How do we do better to say, well, I need this type of personalized care. I need to know myself. I need to be the expert in my care, that when we are partnering together, I can bring that information forward. You know, within that, how do we have networks to do that? We cannot do it alone. I'm just looking at all of the signs, but it is truly the key of this, whether you are creating a group of healthcare professionals that you trust or whether you have those in the community to advocate for you. The burden shouldn't be on you alone, and it really is a part of your health to not say you're going to struggle or always have to advocate by yourself. Surround yourself with those that uphold you. And I think the last one that I have here is really, I was gonna say take care of yourself only, but I think it's both. You have to take care of each other and take care of yourself even when we're going into these spaces. So we are aware of what is preceding us. We are aware of what the notions are, but we can go in there with awareness of self. And I think that's the way that we really strengthen against some of these stereotypes and preconceptions and take care of ourselves. So that's my part. And hopefully we can discuss. Thank you.
Thank you so much, Lydia Joy, for that amazing presentation. Just by show of hands, how insightful was her presentation? And I like that she provided some tools with how we can navigate the system. So I do now like to introduce our second guest speaker, Arnold Pinnock. He's an actor, he's a writer, and a producer, okay? So he's a Canadian actor whose career began at Toronto's Second City Main Stage, born in the UK, doing sketch comedies, how he started. His work in film and television has spanned almost 3 decades, with over 12 plus credits to his name. On the big screen, his highlights include Exit Wounds for Warner Brothers, starring opposite the late DMX and Steven Seagal, the fantastical comedy Down to Earth with Chris Rock, who we all know, and in 2019, he played opposite Liam Neeson in Cold Stage Pursuit for Lionsgate. Other notable projects include Altered Carbon and The Night Before Christmas, both for Netflix, and many others. But currently, his current role is a co-creator and co-executive producer of The Porter, which I encourage we all add to our watch list, a CBC and BT co-production period drama. So let's give a warm welcome to Arnold Piddock.
Way too long. I should have had a shorter one. But first of all, I want to say thank you to Derek for asking me to be a part of this. I feel like very low on the totem pole compared to the rest of you ladies. But I'm just going to talk from the heart, if that's okay. I know how much this organization means to Derek, of course, with his mother, one of the founders of it. And when he asked me to be a part of it, I was like, I'm there, no hesitation. As Derek knows, I'm very close to my mother. I lost her about 10 years ago. And I thought about what I was going to share when I came. And I thought of this story when I was a little kid living in England. And I remember being in the kitchen. My mother was wrapping up a rum cake that she just made in wax paper. And she dressed me up in my best Sunday best, you know? Put the Vaseline, rub it all over my face. I always thought she would do that because she wanted me to look like the holiest kid on the street. And there we were, walking through the community as she held my hand. And we would arrive at someone's house, knock on the door, and sometimes it was the home of someone who had lost someone. And sometimes it was the home of someone who was sick or was hurt. And there was my mother. We'd walk inside, they'd hug, I'd sit down, she'd give me a biscuit to keep me quiet. And they would pray. They would pray. And my mother would give rum cake, and sometimes she carried with her a couple of thermoses. One would have some bush tea. The other one would have some Sarah. And then my mother, if it was someone that was hurt, maybe someone bruised their arm, maybe someone tripped, maybe there was an elder person there, and my mother would tend to them. If they were cut, she would clean the wound. She would bandage the wound. There was always a bottle of Dettol close by. And she would teach the people in that home how to take care of that sick one. And then my mom would grab me, and there we were walking in the community going back home. And I'd look at my mom, and a sense of pride would come over me. And then we'd come back home. She'd get me ready and put me in bed. And the next thing that would wake me up would be the sound early in the morning of my mom praying. Touches me. She would be praying for the people that we helped, for her family back home, and for the rest of the kids. Eventually, she'd make her way down to me because I was the youngest. And then the next thing that I would hear would be the whistle of the kettle. Meant my mom was going to work. I would sneak outside the door and look at my mom, and there she was, pinning that nurse's hat perfectly on the side of her head. A finely pressed white dress. And she'd look back up at me and she'd go, "You want me to come up there and box you, get your ass back in bed, so?" I'd run back into bed. I'd hear the door close. And if I closed my eyes and I strained my ears, I could actually hear my mom's footsteps outside the window as she ran to catch the bus. And I would start smiling because I knew everything was going to be okay. I thought to myself, if I fall while playing in the playground, if I get sick with a cold or the flu, if I get chicken pox or the measles, it's okay. Because I had hope that my mom was going to take care of me. You know why? My mom was a nurse. I'd like to ask you guys if any of you have seen this show, The Porter, and if you haven't, that's okay. There's always time. The one thing that happened for me when I went down the journey of learning about train porters in North America, I went down that rabbit hole. And a few things kept on coming up. One of them was articles on black women that were referred to as Black Cross nurses. Now I can see all the looks on everybody's faces of like, oh my God, what is Black Cross nurses? I had the same look too. I had no idea what they were. But it empowered me to go down that rabbit hole. And if you would indulge with me to read off a couple of facts about Black Cross nurses, I would deeply appreciate it. Can I get an amen? Amen. All right. Black Cross nurses was a branch of the UNIA, Universal Negro Improvement Association, formed by Marcus Garvey, who was a Jamaican, so. And although Marcus Garvey may get a lot of the shine, there was a woman named Henrietta Vinton Davis who established the Black Cross nurses in 1920 in Philadelphia as an auxiliary of the UNIA after World War I. The Black Cross nurses was based on the World War I nursing model of the Red Cross. You see, after World War I, black soldiers were coming back to their towns and their cities with missing limbs, blind, in some cases disfigured. But what they were bringing back to us, which we are in the 1919, after post-war, it was something that we're very familiar with, is they were bringing back with them the Spanish flu. Very similar to, as you guys would say, COVID-19. And that is why Black Cross nurses was brought to be. It's so that we could have an organization that could help us within our communities. Local chapters were established in Alabama, Chicago, California, Georgia, Louisiana, New Jersey, New York, Virginia, and here in home in Canada, Montreal, Nova Scotia, and Toronto. International chapters were in Panama, Trinidad, Tobago, and Belize, where it still is today. The establishment was set up with a matron, head nurse, a secretary, and treasurer to provide health services and hygiene education to black members in the community. Few programs existed which would admit people of African descent into nursing training at the time, and many health facilities provided unequal care to black patrons. One of the goals of the organization was to address these discrepancies. Harlem was the headquarters of the UNIA. It's where Black Cross nurses took courses ranging from 6 months to a year to make sure that the standardization of the care was being given. Actually, it was a tissue I was asking for, but I'll get thank you. In addition, upon graduation from the course, each member required to purchase and wear their official uniform, which consisted of a white dress, an apron, a nursing cap, and a cape. The organization functioned as a social reform movement while deploying role models for young women. It prompted education, good health, and maternal and infant care, and training in proper nutrition. It also provided a professional, organized structure for members, giving them the means to appeal as role models within our community. Black Cross nurses went door to door in their communities, providing public health duties like disease prevention and hygiene education. They also visited people who were ill or injured at home and did home care visits to new mothers helping with childcare. Sounds familiar to me. Makes me think, 100 years ago, there was a young boy, a young girl, walking in their community holding onto the mother's hand. And he would look up, and he would see that nurse's hat pinned firmly in her hair. and a sense of pride would well up in his heart. And he would look at the community as they looked at his mother. But they weren't just looking at his mother, they were looking at a Black Cross nurse. And in their hearts was hope. Thank you very much.
Wow, thank you, Arnold, for that heartfelt presentation. I was really trying to hold up the tears. Thank you so much. And your mom sounded a lot like my late mother, who was a nurse and a community nurse and a babysitter while raising myself and my siblings. And just by a show of hands, do we have any nurses with us, current or retired, by any chance? Okay, please give them a round of applause. Thank you for all that you do for the community. All right, so our next guest speaker is Dr. Danielle Cuthbert. Dr. Danielle Cuthbert is a clinical fellow in the breast oncology at Princess Margaret Cancer Center. She completed medical school and internal medicine residency at Northwestern University Feinberg School of Medicine in Chicago. She then returned home to Toronto in 2020 to continue her education in medical oncology training program at the University of Toronto, where she served as chief resident from 2021 to 2022. Dr. Cuthbert's clinical and research interests are centered on equity, diversity, and inclusion, as well as women's health. She is hopeful to combine her passion for both areas as a breast oncologist with a career focus on tackling systemic inequities within cancer care. She is proud of her Trinidadian heritage. Any Trinidadians in the place? And is an advocate for improved access to oncological care for Caribbean communities. She also has a strong interest in medical education and is motivated to increase recruitment of students, which is important, from underrepresented groups into the medical field. So let's welcome Dr. Danielle Cuthbert.
All right, thank you so much, Stacy, for that warm introduction. It's really an honor to be invited to speak with you all today. This is chapter 2 that we'll be moving on to, and I've been asked to present on a few topics related to breast cancer amongst Black women, more from a scientific perspective and how to really contextualize this within our healthcare system today. So to give you all just some general information about breast cancer, it is the most common type of cancer in women, only second to some forms of skin cancer. And unfortunately, it is the second leading cause of cancer-related deaths. That's secondary to lung cancer here in North America. Many people probably have the question of, well, how prevalent is breast cancer as a whole? It is estimated that 1 in 8 women, so that's about 13% of our entire population, will develop breast cancer during her lifetime, and 3% of all women will die of the disease, unfortunately. Despite that, over the past few decades, there has been a steady decline in deaths related to breast cancer, and that's due to a few different things, including increased awareness of the disease, better implementation of screening, mammography, as well as just advancements in more effective treatments that we've had. Before we talk about the most important topic, in my opinion, which is breast cancer diagnosis and mortality amongst Black women, I just want to highlight that a lot of the data that I'll be talking about and that we have in general about breast cancer and race-based data is that okay? Okay, perfect, thanks. Comes from the United States. And while this is certainly really valuable, we have to recognize that we are not in the United States. Our countries are very different in many ways, and we can't translate exactly what their findings have shown to our setting here in Canada. For example, the US uses racial and ethnic groups such as Hispanics, Asian Pacific Islanders, and that just doesn't exactly correlate to our setting here in Canada, and are not terms that we're nearly as familiar with. So please interpret the data with a grain of salt. That being said, there are lots of initiatives and efforts underway here in Canada to try and do our own research to apply and understand race-based data within oncology and understand disparities within our Canadian context. So with that, let's delve into breast cancer risk amongst Black women. And I want to draw your attention to these figures here. So let's first take a look at the one on the left, and I apologize for at times having my back to you. But the first figure, if you want to take a look at the first two columns, this is looking at rates of what's called incidence or new breast cancer diagnoses amongst white and black women respectively in the first two columns. If you look at the light pink, that is new diagnoses. And you actually see that the rates are fairly similar between the two racial ethnic groups. However, I want you to take a look now at the dark pink, so the lower bars, and that's looking at death rate or mortality. And unfortunately, we know that the death rate from breast cancer amongst black women is 40% higher than what we see in white women. And amongst younger women less than 50, the death rate is doubled. So that's pretty staggering. Then please, if you can see the second bar graph, what that is showing you is the distribution of what we call breast cancer stages according to race and ethnicity. As many of you probably know, breast cancer is staged as stage 1 to stage 4. Stage 1 being disease that's only localized in the breast, and stage 4 being disease that's spread outside to other parts of the body. Again, the first two columns are white women and black women respectively. And the dark pink is, again, localized disease in the breast only. And in the lightest pink, just under the gray, is distant metastatic disease. If you look at these rates amongst black women compared to other racial counterparts, especially white women, you see that they have the lowest rates of early stage disease and unfortunately the highest rates of stage 4 metastatic disease. So I think that these are really important takeaways. Again, data from the United States, but still very, very powerful data to try and understand this disparity. So if we can go to the next slide, please. So I want to explore, I'm sure a lot of you are thinking about what accounts for this gap. First, by bringing up the topic of genetics and whether that has anything to really do with what we're seeing here with, again, a really staggering gap in terms of mortality. So several studies have shown that black women are more likely to have what's called triple negative disease or triple negative breast cancer. And we can talk a little bit more about what that means, but that is unfortunately a very aggressive form of breast cancer. However, we also have to recognize that the term black women includes many diverse groups from all regions of the globe and is not one homogeneous group and entity. And there have actually been a couple studies to look at this a little bit deeper. And what we've seen is that triple negative breast cancer varies it's not just prevalent amongst all black women, but varies based on the country of birth. And studies have shown that women of West African descent have the highest rates of triple negative breast cancer, followed by those who are Caribbean born, and then those of Eastern African descent. So we really need to unpack this further and understand if there truly is a genetic basis to what we're seeing. And I think overall, as we're doing more research in the field, this just highlights that we cannot simply generalize black women as a homogeneous entity when thinking about the biological risk of breast cancer and if there is truly a biological risk of breast cancer. So next slide, please. Instead, and Lydia Joy spoke to this very well, we really need to understand race as a social construct when thinking about why this disparity exists and how it impacts health outcomes amongst black women. There have been many studies that unfortunately have showed that black women are less likely, to undergo screening mammography and experience significant delays when it comes to starting their breast cancer treatment, especially compared to white women. We know that groups from lower socioeconomic status who face financial and social hardships experience significant structural barriers and challenges navigating their care, and oftentimes have to be their own best self-advocate more so than white women. And we also, of course, need to recognize the role of systemic racism, which is prevalent in our societies, including, unfortunately, the healthcare system, including things like bias and discrimination faced by healthcare providers, and how that contributes to worse health outcomes between black women and their racial counterparts. So I'd argue that this is has much greater impact on what I've shown you in terms of the data rather than the question mark of genetic risk and whether that is truly what's at the forefront of driving this difference. So lastly, I'd like to end on a more positive note with some tips on how you can all be your best self-advocate and take control of your health, because I think that's all what we're here to learn more about today. The first tip is to really try and understand your personal risk of breast cancer. We can sort of think about this within what's called modifiable and non-modifiable factors. And if you think about modifiable factors, those are things that are within our control to try and change. Things like the amount of exercise we get, our diet, the amount of alcohol we consume, stopping smoking. Those are all things that are within our power that can affect our risk of developing breast cancer and other diseases in general. Then you have non-modifiable risk factors, which are inherent to who we are. Those things include our family history, our genetics, our breast density as examples. And I think the more you know about that, sort of the best informed you can be to really decide, when is the best time to start screening and talking to your doctor about your risk of developing breast cancer. Secondly, I want to encourage you all to be aware of your breasts and your body in general. Get to know them so that if you recognize any changes, that would be sort of the first sign to you to speak with your doctor or seek care, to ask for not only an exam, but for imaging of your breast to be done. This can be difficult for women of color, especially when so much of what we see online are white bodies, and we may not necessarily know how a breast cancer may develop or look in our bodies compared to what is just otherwise in social media and in medical literature. But there are great resources that are starting to be developed to try and represent our bodies more and more. Number 3 is get your screening mammogram every 2 years. That's currently recommended for women in Canada between the ages of 50 to 74. You may ask about younger women and what to do between the ages of 40 to 49, because we do see a significant number of breast cancer diagnoses in this age group, especially amongst Black women. This is a very hot topic currently, an area of ongoing advocacy here in Ontario and Canada to try and expand and lower the age. So please stay tuned for that, because I'm hopeful that we will see changes in terms of our screening recommendations. Currently, if you are a woman between the ages of 40 to 49 and you have a concern or a family history, the recommendation is to have an individualized conversation with your doctor, and he or she may decide to refer you for a mammogram earlier. Number 4, I'd recommend just maintaining a healthy lifestyle. We've already talked about that a little bit higher up in terms of prevention of breast cancer, but this is really geared for those who have breast cancer and what you can kind of do to improve your outcomes overall. Research has shown that trying to be active as possible and exercise, of course, within the context of going through treatments and all the other stressors that you may be experiencing, does actually help in terms of improving quality of life, reducing side effects from treatment, and actually helps to improve overall survival. And then lastly, seek out resources and support. We are lucky to be in a city like Toronto, where there's many great medical centers. Most hospitals do have social work, mental health services, psychology. So your doctor and healthcare providers should be speaking with you about these and offering them to you. But if they don't, I also encourage you to advocate for yourself and ask what resources are available to you. There's also some hospitals that have libraries and resource centers where you can review literature on breast cancer. And then beyond the hospital, thinking about what's available to you in the community. That includes things like the Olive Branch of Hope. I think there's great power in finding individuals who you can relate to, who are going through similar experiences and can really be there for you as you're on your cancer journey together. And then there's starting to be, I should say, and already a few great online resources that I encourage you to check out. That includes the Every Breast Counts website. I'm not sure if those of you who've seen that already. That's been created as a partnership between Women's College Hospital and the Olive Branch of Hope, and is really a dedicated webpage for women with Black women with breast cancer or wanting to learn more about how they can best advocate for themselves in terms of prevention of breast cancer. So with that, I'd like to thank you all and happy to take any questions during the Q&A period. Thank you.
Thank you so much to Dr. Cuthbert. That was amazing and really helpful. So our final speaker for this session will be Nadine McKenzie. And so we'll hear from Nadine and then we'll go into a moderated discussion where we'll open it up and invite you into this discussion as well. So I hope you've been, taking some notes to ask us questions. Nadine McKenzie, we're so happy you're here with us today, was diagnosed with stage 4 breast cancer in September of 2022. She is a writer, a mother of 2 young girls, and an Black business owner of an incubator called Melanin MRKT, and has become an advocate for Black women's health and is bringing awareness to living with cancer and disparities in representation. So let's give a warm welcome to Nadine.
Hello? Alrighty, okay. All right, so last September, I was getting a pain in my chest. I was working, and I just kind of summed it up to being my period, just a little swelling in the breast, anything like that, and I really dismissed it for quite some time. About a week went by, and I was still getting the same pain in my chest. And so I was like, oh, this is so weird why I'm getting this. I was talking to my friends about it. I'm like, I'm just getting this pain in my chest. I don't know what it is. But I'll find the time to go to a walk-in clinic and I'll get it checked out. I don't know if you are like me, but I had the same doctor for my entire life. They retired, and then I've been without my own family doctor for the last 5 years. However, I have been on Connect Care for the last 7 years. I'm still waiting for a family doctor. But yeah, so I was getting this pain in my chest, and then finally I was like, I really got to get this checked out. And I started trying to go to walk-in clinics. And every time I went to a walk-in clinic, I was immediately met with, we're busy, we're closing early, and I could not get any care. It took me about 3 weeks. And eventually I just said, you know what, I'm just gonna go to the hospital. I'm gonna take the day off of work. I'm gonna take the 8 hours, and I'm just gonna sit and wait because I need to figure out what this is. In those 3 weeks, of course, I started doing my own Googling. I started looking because naturally your first fear is like, oh my God, there's a pain in my breast. Is it breast cancer? But then I went online and I looked and I'm like, oh, it definitely cannot be breast cancer because I don't have dimpling of the skin. I don't have leaking coming out of my nipple. My breast doesn't look like an orange peel. My breasts look totally normal. And then rapidly within a week's time, there had been a lump that formed in my breast that was about this wide. So when I went to the hospital, they did a biopsy on me. I was there for 8 hours and they finally did a biopsy on me. After the biopsy, they said, no, we really do think it's cancer and we're gonna follow you up for some more testing. So that was that. And then I got more testing done. I had a mammogram done. I had an ultrasound done. And I'm going to pause on that ultrasound and biopsy part because as we were just discussing how Black women are perceived and how our pain tolerance worked, that biopsy, I had a white male doctor who had stabbed me and literally the needle had gone past the tumor into my breast on 2 separate occasions. But again, I'm a Black woman, my pain tolerance is higher. Regardless, fast forward, I got the results back and I was diagnosed with stage 3 breast cancer at the time. So that meant that it had already spread past, outside of the breast into the lymph nodes. And so that's kind of where we thought it was. Now I'm Googling still, and I'm like, how is this possible? Because all of the signs that I looked for to find, I did not have. And then eventually when I got my CT scan back, it was revealed that the cancer had spread from my lymph node to both of my lungs. I am a mother. I'm 39 years old at the time. I'm approaching my 40th birthday party that I've been planning for the last 6 months. And I have a 4-year-old and a 7-year-old daughter, and I'm a single mother. That was a very devastating time or moment in my life. And because there's such a stigma around cancer, in my head, this is not my disease. This is my auntie's disease. This is the disease that we have heard, your auntie got breast cancer, your auntie beat breast cancer, then she got it again and died in 3 months. That's what I know of breast cancer when I hear about it. And when I got my diagnosis, that's how I felt. That's what I thought was gonna happen. I remember being afraid of going to sleep with my kids because I just thought they were gonna wake up and find their mom dead. Now I say that to say, without having information and representation of what it is to live with cancer and how that looks and have those dialogues and these conversations, that is how everybody is gonna feel when they are diagnosed. I didn't realize how many people were living with breast cancer. I didn't realize how long people live with breast cancer because we don't talk about it. And I had to kind of make a choice for myself and for my peers and for other Black women like myself under the age of 40 to say, I'm going to speak out about this because we don't know. And oh, there she goes. There's my titty right there. So it was very important for me to take this photo and show people what it looks like, because to me, that looks like a very normal breast. I'm 39 years old. I'm not even in a position to request a mammogram, and I currently have stage 4 breast cancer, and that's what my stage 4 breast cancer looks like. And if I silently just dealt with this by myself, I know that I would be contributing to another Black woman who was not saying, I need to go advocate for myself and go and get checked. And so I started to use my social media and my platform to say, hey, have you got your mammogram booked yet? Have you booked an ultrasound? Have you done these things yet? Because I got stage 4 breast cancer and I was at the club a month ago feeling very fine, right? And that's what it looked like. And then something really amazing happened, because a lot of my peers and women my age and younger than me were like, I'm gonna go and book my mammogram. I'm gonna go book my ultrasound. Those are my tribe right there. But yeah, and then I got the feedback that they were not getting them. Their doctor said, you're not 45 yet, you have to wait until you're 50. My cousin, whose mother was dealing with cancer and whose cousin was dealing with cancer, went to her doctor and said, can I have a mammogram? And they said, no, you need to wait until you're 45. Now for me as a Black woman being diagnosed at 39 with stage 4 breast cancer and then being told that I can't have a mammogram until I'm 50, that sounds like a death sentence to me. And so I have made it my point to advocate and speak out about it. But not only do I want to speak out about getting screened and getting tested, I also want to create the dialogue of living with cancer so that when someone does get the diagnosis, which we will get, right? God forbid, but there will be more women like me who are going to be diagnosed at later stages, at earlier ages. I wanted to make sure that their first fear was not, are my kids going to find me dead? But they'll say to themselves, oh, this woman is still working. Oh, this woman's been alive for 20 years. Oh, this person is thriving. These are the things. You never know what someone looks like. You never know what someone is going through, but it's important that we have representation. So even in my business of Melanin Market, that's what it's always been about, is about representation. And so in the healthcare system, that same representation is exactly what we need. And so that is why I'm advocating here today for that exact reason. And on top of that, once I was diagnosed, the first place that I was sent to was the Olive Branch of Hope. And I ran from the Olive Branch of Hope like the plague. I wanted nothing to do with it. I wanted nothing to do with being a cancer patient. I thought it was an anti-organization. I'm like, I'm young and I don't want to be a part of this. And they cornered me. They called and harassed me, and I was avoiding. They finally got me, and I went out to an event, and it was the most incredible event that I went to. I was received by so many different women, and the best part was that they took my feedback on why I felt like my representation wasn't there and invited me in and asked for my ideas and how they could help other women moving forward and bridge the gap between this auntie's disease and the breast cancer and living with breast cancer. So with that being said, I just wanted to thank everybody for your time. I will ask I will answer any questions in the panel discussion. But yes, thank you very much for your time.
Thank you so much, Nadine, for sharing your story. You're truly a champion to be here with us and to be fighting. And we got to have the faith that you'll make it. So I do want to invite our panelists to join me for a conversation, but if you have like a question you just want to ask them, we could start with that, and then I'll go into some of the questions that have been pre-designed. So you can probably just start with raising your hand, and then I'll come to you.
Just a quick question. You can go for everyone. I absolutely believe that early detection is the key, but there are restrictions that, I guess, in the medical field that's preventing the, the acceptance of requesting a mammogram and receiving one. And I heard that there was a few that have requested, but my sister, she's 46 and she's been trying to get one for years now, and her doctor keep telling her she has to wait until she's 50, but her daughter just got diagnosed at 23 with breast cancer. And she is still declining, being declined a mammogram, and she's 46. Ooh. So any way we can go around that, any thoughts about that, that would be great.
Well, this one? I don't know what's going on with the mic.
Do we have like a wireless mic maybe for you? I'll take another one for you. Go ahead.
One of the initiatives that I wanted to set out and do, and why I teamed up with the Olive Branch of Hope, was because of the feedback that I had been receiving from several women saying that they were having that exact same problem. And so we are currently working on, we were hoping to actually have a finalized date for you guys today, but there will be one coming up soon, but we will be organizing our own drop-in mammogram clinic. Thank you. Our own drop-in mammogram clinic.
It's still not working. Don't worry, we're going to get a mic that works for you. But you can just project for now.
We will coordinating a drop-in mammogram clinic facilitated with the Olive Branch of Hope, Melanin Market, and Tropicana Community Services. We will be registering people to come. We are going to have a mobile screening unit. We are going to have nurses, doctors. We have received a ton of feedback, a ton of volunteers and healthcare staff that want to be involved in this, and a lot of media coverage that want to support this as well. And we're going to try to do this as many times as humanly possible, because again, we don't have time to wait on them to see the importance of this, and we just have to advocate for ourselves. So please stay tuned, and then hopefully we can start things like this in many organizations and many different communities. But again, that is something that we have kind of in the pipeline that we are going to be working on for that exact reason.
That's awesome. And I just want to add, because my other hat is government relations, so one of the things that our community needs to do more of is call our MPP and let them know that this is a pressing issue. We're all taxpayers, you're a constituent. So by the time the legislation is rolling down the pipeline to hopefully make the change, the MPPs can say, oh yeah, my constituents keep calling, they keep emailing about this issue. So that's another way to kind of raise awareness and to advocate and ask them to push the Ministry of Health to make those changes, so that there's another tool of putting the pressure on our existing system, so that way there isn't this barrier of access to care when you're requesting and the doctors are saying you're too young or you don't need it. And I've had to experience that, where I had a certain type of cancer screening, like, oh, you're too young, why would you do that? And I had to go through a private doctor and get a requisition and find those loopholes in order to do that, but not everyone could do that. But contacting your member of parliament is also another option you can consider. Does anyone else have a question before? Okay, June?
First of all, I just want to thank each and every one of you for being here today. So much information. We could go on for weeks, and I have about 1 million questions. First, I just wanted to say that I wish that when I am, next month, I'll be 10 years cancer survivor. Thank you. So I wish that on the offset, we would have had that conversation about what to expect after you've gone through the journey. Like, what's your body going to look like? What's it going to feel like? What's going to happen after you have the surgery with your keloids and the lymphatic system, et cetera, et cetera? But my question really is, I had a double mastectomy. Now, what do I do about screening? What kind of screening is there for me to do? I can't do a mammogram. What am I feeling for? What happens now? So, Dr. Cuthbert.
Is this on? Is this on? Yeah. Mm-hmm. That is a great question, June. Can I ask what type of breast cancer you had? Estrogen, progesterone, HER2? Triple negative breast cancer. Triple negative. Okay. And you're 10 years out? Yes. Okay. Mm-hmm. That is a great question, and I think something that causes people a lot of stress and anxiety as to, when you see with other cancer types, people have some sort of surveillance after they've undergone their treatment, whether that's CT scans or routine blood work, to try to look for a recurrence. Breast cancer is the exception to that, and this is one of the most difficult questions to sort of answer when you're sitting with the patient, looking them in their face. So you're right that currently, after somebody has gone through their curative treatment, as you went through, the only recommendation is to really do a mammogram to look for a recurrence locally. That can cause people a lot of stress when they know that there is a chance, a small chance, but a chance of it recurring elsewhere in the body. So currently, what we recommend, and I hope that your doctor has told you this, are sort of the signs and symptoms to look out for of if it has recurred, because the chances of it coming back in the chest is minimal, right? There's potentially a risk of it being in the chest wall, so that could be a new lump or bump that feels or looks different, but that is, very, very, single-digit percentage points of a chance. Otherwise, it would be the other parts of the body which recur, which is a scary thought, but signs and symptoms to think about are what we say are new things that are not normal for you and persistent. So back pain that feels different, weight loss that is not, attributed to lifestyle and diet and exercise changes, shortness of breath, all really scary things to hear about. But I think just being on top of that and trying, and hopefully having a good doctor who's also seeing you at least annually to review all of that with you is very important. I will say, though, to hopefully give you a little bit of hope, is that triple negative breast cancer, despite what I told you about being most aggressive, if it recurs, tends to recur within the first 5 years. So the fact that you've made it 10 years out is wonderful. So congratulations. That risk really does drop off quite significantly after that 5 to 10 year mark. So hopefully that gives you a little bit of sense of things to look out for.
Can I just follow up?
Yeah, of course.
I followed someone on Instagram, and I noticed in her feed that she was talking about triple positive.
Yes.
And I thought, where have I been?
No, yeah, that's a great question. So essentially when you have a biopsy, as Nadine spoke about her experience, and a doctor looks at your cancer cells under the microscope, they're looking at what's on the surface of them. And that includes 3 things: estrogen, progesterone, which are our female sex hormones, and HER2, which is a specific protein. And if your cancer has grown in response to all 3 of those, that's what we call triple positive. Yours was triple negative, meaning you didn't express any of those. And I'm guessing did you receive chemotherapy? Oh, yes. Yeah, chemotherapy. Oh gosh, I'm sorry. Yes, it can be harsh to receive, but that is because there's nothing really actionable to target on the surface of those cancer cells. That's usually what people with triple negative disease receive.
So before we go to the next question, I have a follow-up question related to June, and this is for you, Dr. Cuthbert. So when we think about this mammogram, ultrasound, when to do which, because there's some women that don't want to do the mammogram because of the stories, it's painful, they're going to squish your breast and all that stuff. Right. So then they'll do the ultrasound. Like, is there a main difference? Is one better than the other? Should we do both?
Great question. Yeah. I completely understand you. I myself have had a mammogram at a young age. They're not pleasant. I wish there was a screening test that was done that was not painful and didn't cause that much sort of stress and anxiety. Unfortunately, we know that comparing mammogram to ultrasound, mammogram is just more accurate at picking up abnormalities in the breast. Ultrasound is great for some things, but it does miss what's called calcifications, which if anybody has had a mammogram report, they may or may not have seen that as one of the findings, which can sometimes be associated with breast cancer or other abnormalities. So those calcifications are missed on ultrasound, and ultrasound can sometimes miss small tumors that mammogram is better at picking up. That being said, there definitely is a role for ultrasound, especially in younger women. We tend to have denser breasts. And if you're in the 30 or even 40 age group and you have a concern, your doctor may actually decide to order an ultrasound first. Mammogram should be done to complement that, but ultrasound in women, younger women with denser breasts, it has its advantages, absolutely. And then as Nadine talked about in her experience, once you're sort of undergoing the diagnosis of breast cancer, a mammogram and ultrasound really complement each other, and ultrasound is usually done at the time of a biopsy as well.
Okay, that's really helpful. Thank you.
No problem.
So we'll turn to the next question.
Stacy, question. I was going to bring up the point about ultrasounds.
Okay.
And in June's case, I mean, isn't that an option? That was what I was going to ask. I mean, it's better than doing nothing at all.
Yes,
I understand the calcification point that you made, but in June's case, I was going to ask, well, can she not do an ultrasound? If she can't at least do the mammogram, she can do an ultrasound. That's what I was going to bring up.
Yeah, that's another really great question. I would there's a couple different options. If there were to be concerns about what is now left, which is what we call the chest wall. So things like muscle, a little bit of breast tissue, but very small amounts. Sometimes things like MRI are actually done just because they're better at looking at some of those deeper structures. Ultrasound, just of the way that imaging is done, there would be a lot of shadowing is some of the terms that we use when you think about sort of the bone structures that are under there. So I would think that something like a MRI might actually be a just better test in somebody who's undergone mastectomy in that situation.
And would that be yearly?
That could be. I mean, access to MRI currently
it's a wait.
is really, really difficult. I mean, yeah, I think I'm curious what the recommendation is, for example, in places like the United States, which don't have socialized healthcare system. But even so, I don't think they are recommending that. But certainly in somebody who's had, just a lump removed from their breast, or just one breast removed and they have their other one, mammogram done every year, plus or minus MRI in certain situations, it's currently what absolutely should be done on an annual basis.
Thank you for your question. So we'll take one from this side, and then I have a couple, and then we'll come back to the audience. So we'll take this last question here.
Hello, everyone. My name is Charlene, and come March, I will be 9 years cancer-free. I was diagnosed. God is good, right?
All the time.
So, Lydia, you mentioned mistrust and the mistrust within the healthcare system. And one thing that I struggled with, like you, Nadine, was this sense that I had to, when I was diagnosed, I had to be strong. So there was a sense when I would tell like relatives, especially older relatives, I said, no man, not tell nobody, keep it a secret. And this was a thing that we're not supposed to talk about as Black women, right? So I suffered alone. I wish I had olive branch or hope at the time. But like you, it wasn't my disease. So I would go into my chemo session with hat, hoodie, go in, didn't want to see anybody, right? Because it wasn't me. I just wanted to get in and get out. But the moment I stepped out of that and I began to speak about it, like you, that's when women were like, really? This is my disease too? So an organization like this, I mean, I can't tell you how valuable this is for me. And the fact that you're doing it on your social media and you call them your tribe, bringing them to your circle, how important that is. And I know you guys are taking volunteers. I'm signing up. I'm ready to be a voice. So again, I just want to thank all of you for doing what you do. This should have happened a long time ago, but at least we're here and we're on that journey. So I commend all of you and everybody here today who's sitting in and listening. This is just one step in the right direction, and God bless you all. Thank you.
Thank you so much for your comments and sharing your story. And there's a follow-up to what you talked about with this mistrust, right? The mistrust of the system and us not wanting to take the test because we don't trust the system. So hopefully all of you can comment, but I do want to start with you, Lydia Joy. How can we address this mistrust, like as a community or within the healthcare system? Is there some things we should be doing collectively? Is there some systemic things we should be pushing to change around that? Yeah, I know, it's a deep question.
I think it starts with conversations like today. So I think for so long, we just assume because it's the medical system, it must be right, it must be validated, there must have been science behind it. And I think what I have seen, like pulling back that curtain, is that everything we need to challenge. Like, there's a respectful way to do so. And I think, whether you were saying through politics, through different areas, we have to challenge and question what has been normal. So I think as the community, we ask those questions. We don't just accept these numbers that we saw. We're dying at a 40% higher rate. All of these things are happening. Well, why? When we know that the bigger contributing factor are social determinants, those are modifiable factors. So I think as a community, we have to demand to look at, when we've accounted for all the things that we can't do, where can we say these things have to change? And we know that some of those factors are things like anti-Black racism. They're things that here in Canada we pretend do not exist, but they massively impact our health. The stress that it brings when we're going through the system, how we can talk about ourselves, those things, as a community, we have to normalize these conversations, and we have to be able to come to the system to say, yes, you're an expert in your area, but I'm an expert in me, and I'm an expert in my community, and we need to work together in this field.
Thank you. Anyone else want to comment on what we can do?
I'm so big on just having the discussions. We have to stop dealing with, as much as we talk about community in so many areas, when it comes to a family member that is going through something, and that could be anything, not even just breast cancer, but anybody gets sick, it's literally just, we get sick, and then it's very hush-hush. You would not even know your brother-in-law is dealing with something or anything like that. We just know somebody's sick and we don't know about it. We have to start having the dialogue. We have to have healthy dialogues about it so that we can bring all this information together as a community. We cannot continuously sweep these things under the rug. Otherwise, we're not going to understand the experiences of other people and realize that, no, this is not okay. This is not normal. Oh, this happened to them too. Like, now this is a thing. We got to look into it. Like, again, if I didn't speak up about what was happening with me, then I wouldn't have heard the feedback that there's so many women that are being denied mammograms and things like that. So like the dialogue and having the conversations is like imperative just for us. And I really try to speak not on what they're going to do for us, but just what we can do for ourselves at our table and that.
Anyone else want to comment on the question? Or? Okay. All right. I will move to the next one. So this is more about hopefully solutions, and we want the audience insight on this as well. Would having regional healthcare centers in Ontario designed by Black medical experts exclusively for Black community improve health outcomes, or could it negatively impact healthcare needs? So who would like to start with this one first?
It's giving you. Yeah, I think
Dr. Cuthbert, any thoughts on that?
Sure, yeah. I think there would be great value to that. Certainly. I think that we know that race congruent care, meaning patients of a certain cultural or racial ethnic background who see themselves reflected in their providers have better experiences. The communication is better. They feel more listened to and heard and appreciated, and their health outcomes are actually better as well. So I think there really needs to be a push for that, and that comes to increasing the pipeline of Black trainees as well as trainees from other racialized groups. So I think if we could create that, it would take a long time, but I do think that would be hugely impactful. One of my concerns, though, with that is that currently when we think about things like clinical trials, those tend to be concentrated in certain academic centers in downtown hospitals. Yep. Not exclusively, there are clinical trials at other hospitals, but the bulk of them and sort of the most cutting edge ones, again, tend to be at a handful of centers. So my concern with that, or I think what would also need to be done, is ensure that there's a good referral process for these Black centered centers to ensure that these patients are not missing out on access to research and other sort of more novel therapies as well, and not sort of excluded in that sense. That would be one of my concerns.
Anyone else have some comments? Yeah.
I think I'm of two minds. I think we have to hold the systems that are here accountable. Like, we pay taxes, so I want to see what's in existent, inclusive, and representative of us. But I think investing in programs like Olive Branch of Hope, like I think we need to do for self. I really think that, you know, the actual medical care, if we are looking at the systems and saying, let's make sure that that's equal, but then we have support systems that are outside, I think both need to be invested in. Like, I see the amount of fundraisers we have to do, all the things, like, this should be part of care. It shouldn't be an extra and something we're begging for funding for. Like, that is actually a critical part of our care, and I think that's just as important too.
Wonderful. Arnold, do you have any thoughts?
Yeah, in the show The Porter, one of our lead characters is a Black Cross nurse, and she opens up a clinic in the neighborhood in Saint Antoine, which is now Little Burgundy in Montreal. And in our show, the community is thankful because they were afraid to go to the hospitals for all sorts of reasons, the treatment that they were receiving there. So the Black Cross nurses, like I said before, in the sense that was formed by the UNIA, now the community had a safe environment to go. And even though that is somewhat fictional, we wanted to do that in our show, once again, to showcase hope. So, you know, when you were talking about that mobile thing, I was like, okay, we got to talk.
Guys, awesome. Thanks for those insights. So just by a show of hands, how many people feel having regional healthcare centers could improve our health outcomes, just by a show of hands? And how many people think it could potentially have negative impact, considering what Dr. Cuthbert said about the funding, because we have to realize we're taxpayers. So we need to make sure we have the adequate funding. So how many people feel a little bit concerned because of perhaps the funding challenges that it would have a negative? Okay, so perhaps like an integrated approach where this is like a government, funded, so we need to make sure the funding is secure for something like that, We do want to have it, but it has to be integrated with our current system, so we're not cut out of the other care.
Yeah.
Okay.
Hi.
Okay. She's a question? Okay.
Because I want the health professionals who are knowledgeable about the issue to have more of a say. The government's a silent partner in just funding the whole program. I have no problem, but when politics, political science, medical science, it's okay, my concerns and my issues as Black women kind of get lost in translation. Because, like, okay, you know, we can't, the government can tie the hands of health professionals because there is another agenda or purpose they're serving that doesn't have anything to do with me or my situation. That's where the concern comes from. The marriage of political science and medical science. I want it to be, if it is, I want it to be more based in science and asking questions. And if I have valid concerns, I don't want it to be, we can't say anything or we can't shed a light to this concern because it's government funded and it's going to affect the government. So that's my issue. That is my only concern. I love the idea of having these centers, but if it's government funded and government controlled, then I'm not a conspiracy theorist, but I'm just like a little bit like, okay, I'm gonna ask the question like, do I wanna go there? Do I want political science? And I want medical science, not political science. Science is a journey, it's questions. It's not like, it's more subject to facts. And that's what I want. I don't want, I'm saying too much anyway. But that's my only concern.
Those are valid concerns.
That's my valid concern.
Yeah. Those are valid concerns, and perhaps that's why we need a system that's not dependent on government funding to operate, but to help with the infrastructure that's required to build it, for example, and then maybe some private sector, some community funding, like a system where the funding is not dependent, because as you're alluding to, political parties change and they can cut the whole thing, right? We don't want to be dependent, but we do need it because it is our tax dollars, right? So we do need a system to kind of perhaps get it going on an infrastructure level. So there's ways, I think, to flesh this out and explore ideas for what would be best for the community. So you really raised some valid points. Thanks for sharing that. Yeah. Okay.
I just want to relate something that happened to me. I was actually in the hospital on the weekend, right? I was over there. And it was so funny because I was sitting there on Monday morning, and a doctor came up to me, and he's like, "Oh, you're looking good." And I'm like, okay, I didn't know who it was, right? But I thought, okay, maybe it was because I was in Emerge, it was another doctor. And then he said to me, "Oh, I spoke to your daughter." And I said, "Daughter?" He was actually referring to another Black lady that was in the room from me. He had just performed surgery on this woman, and her and I look nothing alike.
Oh my God.
She's darker than I am. She was older than I was. She has completely gray hair, but yet he came in to say that,
That's
right?
insane.
And we're still facing this in this day and age, which is very concerning,
Yeah.
right? So we talk about, when you talk about, historical that this has happened, it's still happening.
Yeah.
And we need to change it. And like I said, it's, by advocacy, because all I wanted to do then was just come out of the hospital. Because if you can't tell, your patient who you were in surgery for a couple hours with, right? That was very, concerning.
And this is why we need to increase the pipeline of Black doctors. And so perhaps the next question could be for you, Dr. Cuthbert. I know you're working on an initiative. How can we increase the pipeline so we have more representation in the hospitals?
Yeah, that absolutely, I think, needs to be done. It's going to take a while, but only really in the past couple of years has that been sort of drawn to attention in our city and our province. I can't speak for other places across the country. But to give an example, I know at the University of Toronto, they are now sort of developing certain pathways and quotas for Black, Indigenous, and I believe Filipino trainees to just be accepted more into medical school and have that support once they are accepted as well. So I think having dedicated pathways is crucial for recruitment. And recruitment really can start, in my opinion, at any age. I think starting in high school or even younger is great. Getting young minds excited about science and medicine, getting them curious is a great idea. And then that should continue, again, all throughout undergrad, making sure they have that support, medical school residency, et cetera. And we're starting to see sort of every step of the way there are recruitment efforts being put in place. But as I've mentioned, I think trying to retain that talent and making sure that they have support in terms of mentorship is also equally as important, because we want them to thrive and succeed. And I think a huge part of that includes having mentors that, again, look like them, that they can see themselves reflected in, leaders in the healthcare industry in terms of, this is tough, but I'm inspired and motivated to be just like X. And I know firsthand that having mentors or role models who I don't quite see sort of a similar lived experience with is different than having that person who I align with a little bit more personally. So I think that's a huge piece that needs to be implemented more in medical education. And I gave the example of U of T. There's individual hospitals that are trying to do similar initiatives as well.
That's good. So change is on the horizon. Yes. My next question is for Arnold, unless you have a comment. Yeah.
Another way, when you talk about youth, is seeing faces like ours in history. And you had a great list of people, and there are so many. We can talk about the negatives and the positives. We can talk about Queen's University and their whole setup of stopping Black people from being doctors and going in that realm. We can talk about Nova Scotia. We can talk about, I apologize, I can't remember the gentleman's name, that was a captain in the No. 2 Construction Battalion, which actually was a doctor, but because of some clerical issues, they never allowed him to be a doctor. And Nova Scotia is actually switching that now, and they're actually giving his family an award. So seeing those sort of things, I just don't want to hear that on 10/10 for 5 seconds. I want to see that, and I think for the youth, once they start seeing themselves not only in history, but in the here and now, it sparks that thing like, maybe that's something I want to do. Maybe I don't want to be a hoopster. Maybe I want to be a doctor. Maybe I don't want to be a music star or an actor. Maybe that's what I want to do. So, it starts there with the youth.
Thank you for sharing that. But the next question is for you, so don't go too far with the mic.
No, but
do you want to comment? You want to comment?
Yeah,
okay, go ahead.
Just really briefly from my seat in Black Health Alliance, the other thing that we've done in the work that you're doing is making sure there's representation on the boards who are deciding, because we can encourage everyone to come, and if they now are not accepted, and we started sitting on the boards and saying, well, we value your experience in community. So maybe you didn't work at your uncle's golf club like your peers, but you worked in community, you worked in a faith organization, you did something else that we can see the value and we attributed value. So that's also important, because the system wasn't made for us. So we can't just say, let's bring ourselves into a system that was not made for us to succeed. And then we have to also support our students on the other end. We can't bring them into a toxic place. I know from my experience in university, I just wanted to run. We were talking about this before. Like, we can't just bring people to a place where you'll also feel excluded and not comfortable, and then not be able to graduate because you are also dealing with these other oppressions. So as a community, we have to help all along the pipeline. We have to help support get in and help support when we're there, that we feel welcome and know that it's for us too.
That's really important. Thanks for sharing that. Anybody else want to comment before the next
I
question?
just want to say we also need to pay these people to stay in. We also need to pay these people to stay in this province and in this country. We're losing nurses and doctors in droves right now to the States.
and we won't get into like why and the hows of that is happening, but like once we have them trained, we need, like, we've lost a lot of nurses due to like their extreme exhaustion over COVID and how our Ontario nurses are being treated right now, and they're just going to the States, like, and so like once we get them here, now we've trained them, now they're in school, and now they've worked a year in the most toxic environment, and they're like, I'm going to Texas so that I can be treated like royalty for my healthcare work. So like, yeah, there's so many areas of work that has to be done, but yeah.
Lots of improvement that's needed. That's so true. So Arnold, one of the things that's important is educating the next generation of Black Canadians about the importance of taking care of our health, and how do you think we can transfer this knowledge to them in the most effective way?
Wow. I don't know if that should be for me, but
everyone else can comment after if they have some suggestions.
I mean, how can I can just talk about my industry. Yeah. And just like I said before, you know, like when I heard you talking about that, you know, mobile center, immediately in my mind I was like, okay, that could be a mini series. Okay, you know, this could be this could be that. Because there is something about, unfortunately, educating people through film and television. And I think what it does is, what we tried to do with The Porter was not so much as educate. We wanted to entertain them. But after that hour is over, we want people to go, wait a minute, let me look into that. Let me take this, this initiative to go online, to buy books, and to learn, and to see if we actually did this within Canada. When we talk about all these doctors and stuff like that, my whole thing was like, I can go throughout the many books that I've been fortunate to read and read about Black doctors, male and female, and Black Cross nurses, and so on and so on. And that empowered me, and if it can empower me, what can it do to yourselves and also to the youth to see that? So I don't know if that answers your question, but to me, it just goes back to, if I can see myself in the pages of history and see what they can accomplish with all of that, come on now. Then there's no excuse for me. You know, that's the way I see it.
And then you'll recognize you belong because you're seeing yourself, right? And that belonging is important as well, right? You don't want to add? That's it? That's a mic drop? That's it? Okay. Now, does anyone else have a burning question before I move to a couple of wrap-up questions? Okay, I see a hand. I saw a hand back there first, the lady with the pink. Okay, we're going.
I just wanted to piggyback on that. What we can do for the future, again, is just to reinvest in STEM education for the younger kids. Yeah. That's how we can change the future. The younger kids are being denied STEM education. I've heard countless stories, you know, of my son, you know, oh, math is probably not your thing, or science is not your thing. They're being discouraged, and that's the reason why we don't have the doctors, we don't have the nurses, and we don't have the professionals in the STEM activity. But we do have a chemist right here, Miss Stella, that's sitting right here. But again, more and more, we just need to educate our kids in STEM activities and push STEM at all costs.
Thank you. That's important.
Oh,
okay.
I had one more thing.
Okay, go ahead. Okay. Go ahead.
You know, we have a situation right now where we've got everyone here. I don't know all the ages, but my thought is, why don't we have our nieces here, our nephews here, to hear this and to hear the, you know, people talk. We don't have that. If we keep it at this age group, you know, we are more on the end of our journey than we are at the beginning of our journey. You know? Well, yes, that's right there. So to me, it's important to bring, you know, for me, my nieces and my nephews to situations like this, so that they can hear it, you know, so that they can know about prevention and stuff like that. You know, when we're talking about, you know, keeping it quiet, just the fact of not bringing younger people, it's the same thing, so. Right? So anyway, that's my thought.
That's a good thought. It's important. Your question, please, or
yes,
comment?
Please. And so, you know, Arnold, we are working really hard at the Olive Branch of Hope to make sure we have content that is better suited for younger people, so that these conversations are presented to them the way how they speak and they would receive it. So thank you. So thanks for the pre-conversation on attracting talent into healthcare that is more representative of our diverse community. That was my first question. The second question I had, so the Hippocratic Oath starts with first do no harm. And alternative treatments and alternative approaches to care are considered inherently harmful because they don't follow the traditional protocols. Is there, without them being able to get the funding to follow the protocol, to prove their methodology, then we're kind of always stuck, right? So is there any more kind of cohesion or moving to the middle? Are doctors willing to ask broader questions, more outside of the box questions, explore things that we haven't tapped into before, instead of just shutting down, right? The other things that we're hearing that may work, it tends to be very anecdotal. So for people like me that like numbers, I can't get numbers, but I can see that there could be benefit to trying something new. So is there more towards the middle coming?
This is exactly a conversation we were having before we started, and I think there is, and I think it starts with changing our language. Like you said, more traditional. Well, this is our tradition, right? When we speak about all the herbs, the ways, the different things that we do, it is our tradition. And so it shouldn't be seen as an alternate. How do we do it complementary? And I think there are doctors who are coming more towards saying, well, let's see if there's actually a harm or whether this can be part of your total wellness. If the one good thing that came out of the panorama of the last 2 years is that we are really looking at different ways of seeing health and really looking at it more comprehensively, and it includes all of this. I think before we were scared to say the things we did at home, right? I think about, you know, when my son's sick and my mom will put Vicks on the bottom of his foot, and I'm like, I can't tell the pediatrician that this is how we dealt with the flu. But now I'm gonna go in and say it because you should know this is what we're doing, and it worked. Yeah. So I think that's part of it. It's like, what does wellness mean, and how do we make sure that our traditions are also part of traditional medicine, and we find ways to, as you said, validation isn't only numbers. Like, I'm a basic researcher, but our stories count as what works. It's not just anecdotal. I find that sometimes we say that as dismissive, but it's actually generational knowledge.
Yeah.
And valuing that knowledge is how we start to change things.
Yes, thank you. Anybody want to comment before I move to the next? Okay. Oh, you want to comment?
Well, we were discussing this before this exact same thing happened. That is why advocating for yourself and doing your own research is imperative. Like, we cannot discuss all of the problems that we have with the healthcare and then rely solely on them to provide information to us. If you are not interested in getting knowledge from more than one place, not one place, but let me read this article, let me read that article. I have gone to my oncologist and asked her so many questions, and sometimes she has tried to dismiss some of them, and sometimes she has taken them on, but like, if I'm unconsciously incompetent, so I don't even know what I don't know. So it is imperative that you go and read all of the articles from all of the different sources so you can then go and advocate on your own behalf. But we have to stop waiting for information to land on our feet. And when it comes to your health and your life and the life of those who love you, like, you have to do the research yourself and then bring those questions to them.
Thank you for sharing that. And my next question is for Lydia Joy. Can you highlight a few programs or examples of how the Black Health Alliance advocates for health needs and concerns of Black communities? Because I know we're not a monolith.
Yeah, I think there's a few, but just kind of in the theme today, a lot of what we've spoken about is like physical clinical work. I think we've pivoted a lot to support our mental health. So we're not a forward-facing clinical group, so we support everyone else who's doing work. Like Olive Branch of Hope is one of our partners. Awesome. But what we've really looked at is, you know, what is the scaffold that can bring us all together? So we have one program that's Pathways to Care that was really focused on the youth. We know how our youth are treated look differently in healthcare, in mental health specifically, and so we really kind of spoke to them of, what do you need? What does that look like? How do we advocate? We've partnered with a program, it's called SAPACY, that's specifically to address Black youth in the system. And likewise, on the other end, during the pandemic, we supported what would be considered frontline workers. We did a pilot to say, can you have a healthcare professional that looks like you? So Black healthcare professionals paired. But what we really fought back was to redefine what a frontline worker looked like. So when it was Sun Life we partnered with, they came in, they were thinking very traditional, use this word again, right? Like just healthcare professionals. And we're like, well, that grandmother in our community who had to take care of those 8 kids while her kids were working, that's a frontline worker, because she didn't get to sit home and learn how to make new bread like other people were doing. And so we were like, how do we support everyone in our community to not just have
this persona of a strong person, that we actually have the tools to be that. So those are the things that we're really focused on, and otherwise partnering with other groups that are doing the work, and we try and find funding and advocate within in policy to make those changes.
Awesome. Thanks for sharing. That's good. Really good work. So in the interest of time, we will take the one question. I know I saw a hand here. I saw this lady here, though, with the hat on first. Derek, so you want to ask your question? Yes, because I did see you earlier. Yes.
I just want to make a comment and ask a question. So again, I want to thank the panelists and the organizers for the session, echoing what other people have said. It's been so informative. And just a quick question for Dr. Carter and Ms. Marshall. You talked so much about race. We know that research looking into the Human Genome Project has said that while we may be 99% the same below the surface of the skin, race can get made above the surface of the skin. Do you guys feel the need to bring in sociological researchers that can talk about the social, economic, and political anti-Black racism, and that really we need to look at the social aspect. So I think this is so informative, and there are so many intersections. Just wanted to add to what's being said, a sociologist that deals with race, that looks at the social determinants of health. Do you think that would be helpful?
I think
you
answered your question. So I think what we often, when we think of social determinants, especially for Black people, people go to economics. And so I would stress, when we're speaking of social determinants, we have to look at anti-Black racism. We have to look at those type of prejudices and all the isms. So there's definitely still utility in saying there are differences. There are geographical differences. There's areas where you have higher risk. We speak in risk assessment. But yes, I think we need to now examine further from a social lens, why are those risks higher? And what are the things that we can modify so that we really know what are risks that might be based on something biological, based on risks that are being imposed on us, and those two need to work together. When the first Human Genome Project was done, it didn't include us. It was like, the 8 university students who were close by, and they mapped out their genes, and they didn't look like us who were in that group. And many indigenous groups across the world, especially in the Caribbean and Canada, actually refused to be a part of that program out of concern that they'd be disenfranchised. What if they then told us, well, you're not actually from here? And so we weren't included in those first mapping. And so there's gaps in understanding our biology, but I think now it's time that we have parameters around it, that we marry the social consequences and see what really are biological markers. So it's absolutely time for both to work together.
Thank you again for your question. Anyone else want to comment? I do have an important question for Dr. Cuthbert. What are some key questions that we should ask our doctor oncologist to better take control of our health?
Okay, that I think we've touched on some of these already. I think one of them is, what type of breast cancer do I have? And that it gets back to what we spoke about earlier, triple negative, triple positive, and understanding those 3 key receptors, as I mentioned, estrogen, progesterone, and HER2. So making sure that you have a clear understanding of what's positive, what's negative, because that really impacts your outcomes, as well as what treatments are offered to you. So I think that is something that, for whatever reason, is sometimes overlooked when patients are speaking with their oncologist, which is baffling, because that is really the hallmark of understanding your disease. Taking a step back, I think it's also really important to understand, do I have invasive or non-invasive breast cancer? I recently had a family friend who was told, you had a biopsy, you need to be seen at Princess Margaret for surgery. That was it. She doesn't know, again, pre-cancer, which is non-invasive, which is treated differently, usually with surgery and radiation, versus an invasive form of breast cancer, which can open up sort of the door to more treatments, and also impacts how you'll do long term. So again, these conversations are not being had, and as unfortunate as it is to say, I think patients, at some times, if that's not being shared with you, these are things that you can ask for as well. And then I think the last one that I'll just mention is the importance of knowing your lymph node status if you have a new breast cancer diagnosis, because the lymph nodes are really the gateway to the rest of the body in terms of cancer cells. And in a rushed appointment, that might not always be clear to you if your disease is only in the breast, if there's a few cells in the lymph nodes, if that even needs to be investigated. So those, I think, I mean, I can go on and on, probably to a list of about 10 plus questions, but I think if you want to start with those three as you're overwhelmed and emotional, understandably, dealing with a new diagnosis, those are the three main takeaways I think you should have after your first conversation with an oncologist.
Thanks for sharing that. We may need to work on a questions you must ask for the olive branch, Derek, that we have that people can download and have as like a guide, as a tool, right? Because this is really helpful and important. Thanks for sharing that. So we'll take one final question from the audience, and then I have a wrap-up question. Your hand went up real quick. So, yeah.
I've been waiting patiently, that's why.
Yes.
And thanks to these ladies for kind of saying stand up, but I have some manners. But what I've been hearing a lot about is the experience. And so my question is that where can one go to website, support, resources to express their experiences that they have been enduring when they're talking to medical professionals? Because I think medical professionals need to be held accountable to the way they speak to their patients and the way they deal with their patients' stories, the way they deal with their patients' experiences, and not dismiss them with reckless language. It's all in your head and everything like that. The experiences are trauma, okay? I work in the healthcare system. I have been on both sides of the spectrum as a patient and as a healthcare professional. And I'm hearing this common theme all the time. If the hospital itself does not have a patient-centered kind of forum where patients can report what is going on that they have experienced in the doctor's office, where can somebody go to report these experiences? Because if experiences and sharing stories is going to make the change, we need to have outlets, and people need to know where these outlets are so they can express their stories. Not everybody has social media. Okay, not everybody likes it or anything else in between. And harboring those experiences is detrimental to the self-care that we are so about advocating these days. So where can one go to hold these medical professionals accountable, dismissing diagnosis, dismissing our feelings, dismissing language, especially in the Black community? I have fought very hard. I've heard people say that they are still fighting for mammograms and ultrasounds. I fought very hard for mine, and I did not let up because I was like, I'm not going to be silenced. I was at 40 at that point, and my doctor said, oh, well, there's no need. No, sir, there is a need. There is a need, because at the end of the day, I have to champion myself. My life matters, and the generations to follow me matters.
Thank you so much for sharing your concerns. Anyone have some comments on?
I love your passion, first and foremost. I love that. And when I started Melanin Market in 2017, it was specifically because the representation was not there. I'm such a big advocate for representation matters, and I feel like that is the constant theme that we're hearing throughout the course of the day. And so anytime I hear a problem, I'm not looking anywhere else outside of myself. So if you can't find it, then we need to create it. And that's that's how I think as people of color, we need to approach every single thing. I'm tired. I'm no longer interested in what's happening at their table, at their board. I do not care. If we need it, then we create it. And that's that. So to me, even as I'm listening to what you just said, my first thought is like, okay, how am I going to create a platform for people to come and express this exact same thing? Like, so just having you speak and say those words at speaking with such passion, then now we all know, and everybody here, and there's so many organizations right now that are working for this advocacy, are now, I'm certain, going to walk away from this and say, how can we create exactly what you just mentioned? So, yeah.
Maybe if we had, like, I appreciate you, Dr. Daniel Cuthbert, for coming. I really do. Maybe if we had more people like yourself, more medical professionals on the panel to hear these stories, maybe they would improve their bedside manner and improve their language and improve their compassion. because, you know, we're somebody's kid. You know, we're somebody's niece, we're somebody's daughter, brother, sister. And I would like the medical community to hear, how would you like if somebody treated your mama like that, the way you're treating me, or treating your father the way you're treating me? That's what I'm saying. Like, I've been on the spectrum, and I've been excused, and I was like, no, I don't think so. And the only reason why they don't excuse me is because I work in the profession. That's why I won't back down for nothing. I will always stand in the truth. And if the truth hurts them, let it set them free. Because I'm very sorry that there's voices coming up, and we need to be heard, okay? We really need to be heard. So I wish more medical professionals like yourself, doctor, can come forth and listen to these panels, maybe have conferences to hear more about the patient experience and value it and apply it to what they're doing. Because some of these doctors, I'm sorry, they're very outdated when it comes to bedside manner. They have no manners, they have no brought up seat, they have nothing. They're out of like anything else, and it has to change.
Yes, I've seen it too. Wow. All right. You said everything we need to hear. Thank you so much. Okay. I know, right? Let's get going. Let's write those letters. Okay, and they are regulated, right? So I hope letters are being written. That's another way. The letters to the College of Physicians and Surgeons, those licensing bodies need to hear those patient stories. So hopefully within the system on how they're trained, they can improve the training, right? And it's more culturally sensitive and appropriate. But thank you so much for sharing that.
If I can add one thing
okay,
to it, just
sure,
you're saying, since we sound like we're going to be starting a program after this, that's exactly one of the things, because it's one thing to tell our stories, but we need accountability. And so what we have really been looking at is, how do we partner, like you've now shared, we don't want to just be sharing to talk. Right? So now what happens? Is there something that happens? Is it recorded? Does it impact your pay? Does it impact your way to practice? And so those are the things that we're working on. So like we are able to gather the stories, and then we are able to say, now how does this impact? I know in other places they have like physician rating, but it's normally like there's other strict criteria, but we want it, and we're advocating for it to include this, include experience and brought up. See, that's an actual check mark we would like.
Yes. Exactly, right? What's the brought up seat level? Okay, so I'm going to do the final question.
Can we get just
yeah, sure. Trying to stay within the, okay, yeah, time.
I don't know if I need the mic. Hi, my name is Stella. I'm here with Carla and Nika. We're from Estee Lauder Companies, and there's an ERG there called Network of Black Leaders and Executives. We find it very important that we need to support each other and rally for each other. That's why that group was formed. We're a global company, but we're the Canadian arm, the branch. And every year, throughout the year, we try to hold events, etc. This year, what we're doing is we're having a fundraiser. One of our colleagues found the olive branch of hope, and I've been sitting here wiping my eyes, getting very emotional, and it's so important. This is something that is important. We need to rally for each other. We need to spread the word. I called my sister. I'm like, have you heard of the olive branch of hope? She called her friend, have you heard? So we're going to spread by word of mouth. And we know funding is super important to have sessions like this where we can educate ourselves, where we can hold hands, where we can support each other. So this year we're having a fundraiser at work. We're doing a raffle. Estee Lauder, beautiful baskets. It's internal though. But every penny we raise, we will be donating to the olive branch of hope so that we can still keep doing things like this. And Estee Lauder has a fundraiser as well, BCC, Breast Cancer Campaign, which is super important because the founder, Mrs. Evelyn Lauder, passed of breast cancer several years ago. So since then, they've been advocating, holding sessions, rallies, etc. So we're partnering with the BCC to do this fundraiser. And this is something that we're going to have on our radar, and we're going to continue doing it, and because we have to support each other. We're all we have, and if we don't support each other, who's going to support us? So thank you again for having me.
Thank you. Thank you so much. And so happy you're here with us. Thanks for joining us. Awesome. All right, so we're going to do the wrap-up question, Derek, or does someone have a question they just got to ask the panelists? Okay, I see a hand right there. We'll take one more. Okay.
I want to thank you guys for a very informative event. I know that you are working in the space of equity and diversity, and the word is spreading. My question to you, and anyone can answer it, if you had to go back to your ancestor, what would you say to them about this that's going on right now? And if you have an opportunity to speak to your descendants, what would you say to them about this that's going on right now?
She's going deep today. She's going deep. She going deep. That could be the wrap-up question. That's a wrap-up question. That's the wrap-up question. Okay, maybe or if you have, I think I have some ideas I would start with.
I think we
go
all do.
ahead.
That is
Yeah.
powerful. I think everybody
That's very
can
powerful.
speak
We
to.
love it. Yeah.
I mean, I think we have come a long way. If I had to sit and talk to my ancestors to say, you know, it's not in vain. We are the ones who are here are the ones who survived. And I would love to go back to say, you know, what you have endured and what you're doing. Like we are fighting, we are keeping that spirit alive. And if I sit and speak to my son, I say, you know, I hope you don't have to continue to fight. I hope that we are doing what is right, that the system will be equal, that when he comes forward, this will not be the same conversation. That equity is not a course or an add-on, it's a basic foundations of all that we do in healthcare. And that's what I speak to him every day, that, you know, sometimes he asks me, why do we have these conversations? Why are you always talking so much? But I hope that it really is a confusion for him of like, oh, I'm treated equally. That is not my experience. And that's what I'd like to see going forward.
Oh boy.
Yeah.
The one thing that comes to mind is just the fact of, if I had the opportunity to talk to my ancestors, just hold on to your traditions. Hold on to those things that may seem confusing and odd to the medical world. But it would have hundreds of years of potencies that worked for people that look like us. So that's the one thing I would definitely say. Great question.
And descendants, though, the descendants?
Oh, I'm answering.
Okay.
I'll take the descendants
You'll
part.
take- okay.
But I'm going to put a bit of a spin on it and think of it as descendants, as trainees who are going to come after me rather than my direct offspring. I echo what Lydia Joy said in that I hope that they will, you know, just be in groups, whether that's medical groups or nursing groups or just the general workforce, and see just a nice blended group of individuals where they're seeing themselves represented at all levels and they don't feel dismissed or they don't feel overlooked and don't feel like bringing up these topics is taboo in some ways or kind of met with awkward silence, which is something that I personally myself have experienced. You know, we live in Canada, it's a socialized system. You know, I did the majority of my training in the US. People oftentimes assume that I'm kind of bringing that with me, and that is absolutely incorrect. We have huge inequities here that need to be tackled. So I hope that the next subsequent generations of healthcare providers in general just, again, see themselves more integrated into the fabric of our healthcare system here. And yeah, that's what I'd like.
And I talk to my ancestors every single day. And that was even prior to my diagnosis. I am very much tapped in. I lost my father to colon cancer in 2017. And he was my best friend. And so I constantly look for him. I'm wearing his necklace. I'm wearing his watch. He's constantly with me at all times. So I'm constantly asking them to continue to guide me, continue to protect me, continue to watch over me. And I truly feel that is what they're doing. And for my children and my children's children, I just hope that they will always, always, always advocate for themselves. I hope that they never wait for anyone to come and save them. And they always play an active role in whatever it is that they are battling. They never wait for saving, and they create opportunities. If they see a problem, that they will always do what they can to contribute to a resolution. And that's, yeah.
Awesome. I think I'll share on this one. So similar to you, I lost my mom to cancer. And I would say to my ancestors, thank you for the sacrifice, those prayers. I keep saying I'm still standing in prayers. And thank you, of course, for her friends. One of my mom's dearest friends is with me. She's like a second mom to me, Auntie Jane, who was also a nurse. And so to me, it's like there are elders, these just community we have is essential, and the fight. But I would say to the next generation, I do say to the next generation, never walk through doors of opportunities alone, even if it's a door like this. Bring someone with you. Bring someone to the table, but also build your own table, because you don't want to force yourself to be at a table that doesn't want you there.
Love that.
Yeah.
I love that.
So I think this will conclude our event, because that was a nice wrap-up question, so I won't ask the one I had. And I just wanted to summarize some key takeaways from today. Always challenge the system. Be your own advocate. Seek personalized care from your network of support, which you heard from our speakers today. Pay attention to changes in your body and get checked. Demand it. Fight for it. Like our friend who said, you got to fight for your health, right? You can't let them dismiss you. And make sure you do your routine cancer screening. And always remember, we don't have control over our genetic makeup, but we do have control over the health choices we make, and our choice is our power. So thank you so much for joining us today. All right. It's a wrap. This was so good. We didn't do a high